So the SWOG 1314 trial was a randomized trial that was non-comparative. It looked at patients with muscle-invasive bladder cancer. Half received dose-dense MVAC as neoadjuvant chemotherapy, and the other half received standard GemCis, and all went on to cystectomy. And the primary endpoint of the study was to validate a Coxon algorithm, which was a biomarker that would predict response to either or both of those chemotherapy regimens. And the primary analysis and the primary endpoint for the study were not met. So the Coxon algorithm did not meet the pre-specified criteria to be useful clinically, but it was a great study and provided lots of tissue and clinical data with which to test other biomarkers. And so we were fortunate to be granted permission to test DNA samples from the S1314 study to validate a biomarker signature that we previously discovered. Just like for the Coxon algorithm, tumor tissue was collected pre-chemotherapy and then analyzed. In our case, we took isolated DNA from those samples, tumor samples, and used the KARAS testing platform to look specifically at 4 genes of interest of ours: ERCC2, ATM, RB1, and FANC-C. And we sought to look to see if one or more of these alterations being present predicted a pathologic complete response to the chemotherapy. We looked at both the MVAC and the GemCis groups in our study. Sure. So we had previously discovered this 4-gene signature to be predictive of pathologic complete response in smaller studies that we did here at Fox Chase at our own institution. And we did a small discovery and a small validation, which showed that having any one of these mutations correlated with pathologic complete response. What this study shows is a true validation of our prior findings, that with a p-value of 0.0006, that having one or more alterations did predict for pathologic complete response. However, for a biomarker to be used clinically, there are a lot of really stringent criteria. The first thing that I will say is that this biomarker should not be used outside of clinical assessment, right? So we can predict what's in the bladder, but if you're looking to perhaps predict that someone has a clean bladder and keep it in place and avoid surgery, absolutely one would need to do a cystoscopy with blind biopsies and imaging to make sure that that's correct. And the other thing is that the test is better at confirming presence of disease when disease might not be present on those biopsies and imaging. So it can take people who have disease that's hiding. It's good at finding those. It is not as good at the converse, guaranteeing that a bladder is clean. So it missed, in a bladder that is clean, it can't, convincingly 100% guarantee that that's the case. And I think for that reason, nobody wants to lean on this test, certainly by itself. What we think it can do, and we've already completed 2 prospective trials looking at this, RETAIN and RETAIN-2, is potentially serve to more safely allocate patients seeking a bladder preservation approach. So I'll explain how we did it in our trial. In the RETAIN trial, we took patients with muscle-invasive bladder cancer, sequenced their pre-treatment TURBT, administered neoadjuvant dose-dense MVAC, and at the end of the 3 cycles of MVAC, we had their mutation status. We looked in their bladder, did blind biopsies, and we did imaging. If the imaging was negative, the biopsies were negative, we looked to the mutation panel. If the patient had a mutation, we were more confident allowing them to keep their bladders and go on to active surveillance. If the patient did not have a mutation, then even if the bladder looked clean, we recommended cystectomy for that group. And that study, there were some interesting findings. We did have some recurrences in the active surveillance group. It isn't perfect, but interestingly, overall as a group, patients who took a RETAIN approach maintained the same percent overall survival, same percent of sort of good results at the end as if we had taken out all the patient's bladders. So It's tricky on an individual basis. None of this testing will be 100% sure. We do know that bladders left in place can grow new primaries and have, new problems down the road that obviously wouldn't have been picked up using this gene signature plus cystoscopy, biopsy, and imaging. But we do think it's a start, and it's sort of a place to go. And I think if someone is seeking to keep their bladder that appears clean after chemotherapy, this test could provide some additional information to sway that decision making, kind of along the lines of how we use ctDNA now sometimes. It's not 100%. We know that. But, we know that having a positive result or a negative result does make you more likely to have a certain outcome, and that can enter the conversation in terms of clinical decision making. So I think the test is what it is. I think we should improve on biomarkers in general, and it may not be this test, right? Could be something totally different that we haven't discovered yet. I think what's clear is that, these 4 genes do have a similar function. They're all DNA repair genes, and that in the setting of platinum-based therapy, it does make sense that having one of these deleted in terms of function would make a tumor susceptible, or exquisitely susceptible to chemotherapy. So there's a mechanistic piece supporting this. I think as we move potentially away from platinum chemotherapy in the metastatic space and maybe in the neoadjuvant space eventually, that this biomarker should not be used. For instance, if you're not using a platinum-based regimen, I would not think that this would necessarily be predictive. I think, in terms of the approach that this biomarker allowed us to test and retain too, I think that approach is very helpful. It's here to stay. We've already seen other studies looking to improve on both the efficacy of the neoadjuvant therapy itself by adding immunotherapy or switching out completely to, like, for instance, an enfortumab vedotin plus pembrolizumab approach. But those new iterations will likely require new biomarkers to then help hone our decision making. A lot of people have talked about imaging as also being looked at to sort of make a deciding factor. So far, we only have MRI data, and the gold standard used to validate the findings on MRI was TURBT with biopsies, which we're doing anyway. So I am waiting for better imaging, truly novel imaging that can really look at subclinical disease in the bladder. I'm waiting for new therapies to improve how many patients we cure with neoadjuvant chemotherapy. And in that setting, new biomarkers to see how many of those patients can safely keep their bladder.